Excellent. There you are. That just that moment of pause created panic in my heart. Thank you for that, Mark.
Did that on purpose.
So again, Mark, do you want me to just put a reminder of the time in the chat, or do you want me to come in and let you know?
Put it in the chat for now. I'm fairly novice at this, but I should notice that.
All right. Okay, I'll put it in the chat. So Mark is going to talk about outcome goals for young people aged 16 to 20 who self-harm, kind of outcome goals for therapy and what's been helpful and hindering of that. And I think it speaks to some really extensive research you've done, Mark, which I'm really looking forward to hearing. So over to you.
Yeah, I'll just get my screen sharing going. I've got so many screens open, following all the different things. So just to introduce myself, Mark, I'm a counsellor. I currently work for the Firefighters charity based in Cumbria, but at the time of this research, which is for my PhD, I've only just submitted my corrections after Viva, so it's not been accepted yet, but almost there after 7 years. At the time of doing this came to my mind, I was working for the NHS in Norfolk under the IAPT service. For those of you who don't know, the Proven Access for Psychological Therapies is a British, well, English mainly, it's not in Scotland, is it? A service for providing accessible therapy to all ages from 16 to death, to end of life. And as I was working as a counsellor with this, I worked mainly with the young people, and that's where my specialisation lies. And I was hearing lots of stories about how people have young people have felt they've been not well served or well treated by previous therapy services that they've engaged with. Excuse me. And the self-harm the people were so hurt by the fact that they'd not got the help they'd hoped for. It really stuck with me. And about the same time, there was a song came in the charts, repeated by Johnny Cash. And these were the first lines of it. I'm sure some of you can visualize Johnny Cash's song when he said these words: "I hurt myself today to see if I still feel. I focus on the pain, the only thing is real." And that has really struck me on how somebody who self-harms can feel, or does feel. And the original Nine Inch Nails song was written by one of the members who was experiencing self-harm. So this research really came about because of that. And in my first part of as most of us do in a PhD, did a systematic literature review. And in the literature review, what was coming up was actually people finding barriers to seeking help, similar to what people have reported to me in the therapy room, that some of them don't actually see self-harm as a problem. Self-harming has been reported as a soothing experience, an actual helpful experience, and some young people don't see that there's a problem, and that's reported in the literature in many places. It's a way of taking control. What we in the therapy world, we sometimes use the term functions of self-harm. And one of the functions of self-harm for young people can be taking control in a way they're not able to take control. The other most common phrase was used was replacing a pain that they could manage because they couldn't manage the other pain of their emotional distress. Sometimes people didn't seek help because their culture or because of the stigma, because of in their culture they were supposed to seek help from within the family, not go to professionals, not to embarrass the family, not to bring shame on the family. By some parents acted quite negatively when they found out their child self-harmed and wanted to keep it quiet, keep it closed, and actually stopped the young people seeking help to try and deal with it themselves. But a lot of young people, and in my experience as well as in the literature, it also showed that they have negative previous experiences of disclosing self-harm. Sarah McDonald, in a systematic review in 2020, reported cases of young people feeling that they were being treated roughly. they were somehow being punished, or they felt they were being punished. They were not being given pain relief. They were somehow get the sense that the person that was treating them was somehow angry with them because they'd caused extra work or they'd done this to themselves. And also young people felt the whole experience of going to hospital and to A&E and being in the public eye and people staring at them and waiting around in the rooms. Or I recently worked with a young person who went to A&E with self-harm, and one of the nurses was really adamant that her friend couldn't stay in the room with her, and she was suffering with anxiety, for example. Those sort of things you can appreciate wouldn't engender young people to seek help again if they became needing of the help. So in my interviews, I interviewed 10 young people from the east of England, so Norfolk mainly. And these people had been through the NHS therapy service, and they'd finished their therapy between 1 and 6 months beforehand. So nobody was actually in therapy when I spoke to them. And I interviewed them asking them about goals. But I think if I remember rightly, I used the words desires or hopes for therapy, which links into what Marianne and Kate were saying earlier on about what language to use. It seemed to work well with these young people. And most of them, if not all, 90% of them said their hope for therapy was to somehow feel more in control of their lives. They didn't actually always use those words, but through a latent analysis of the data, the control seemed to come into it all. So somehow felt out of control, so self-harm was a way of gaining control. And from the therapy, they wanted to learn how to be more in control, to gain more control. Because if you think about a young person's life, and this is just a small extract from my thesis, it goes into more detail on the thesis, is they have little control of their lives anyway. When they're in school, when they're at home, they quite often don't have, especially teenagers, adolescents, don't have their say in the home. They don't have their say in therapy services. They don't have say in school. They don't have say in life generally, because in our culture, young people, until they reach 18, for example, aren't considered adults. And even then, there's areas of society that would still tell them what to do and not ask them what they want. Especially in the therapy services. I've worked in NHS, I've worked in third sector, I've worked in universities. I must say the university was better, but there's still a sense of, when they go into therapy, of having it done to rather than with. A lot of these young people feel as well. So this sense of feeling more in control is not possible in therapy in a way. You can't give people control in therapy. So what I looked at in the thing was, how in therapy could we give them an idea of what being in control was like? So asking them, what would having more control in your life feel like? What would it involve? And a lot of the time it was having agency, making their own decisions, making their own choices. And those of you who are familiar with adolescent brain development, that's one of the stages of wanting more independence, seeking help and support from peers rather than the parents, and generally wanting to rule their own life. And I'm sure some of you, perhaps even when we were teenagers, we wanted to do that as well. I'm sure I did. But these were being denied in the therapy service. The evidence said that they were told how many sessions they were having, where they would have the sessions, what type of they're going to, because the IAP service is evidence-based therapy, is predominantly CBT. And oftentimes the CBT would be delivered in a self-help, low intensity way. And so nobody at any point told me they were asked, what would you like? Would you like counselling or CBT, or would you like to do group work? So even by the very nature of the therapy service, the control is taken away from them. Excuse me. And control is, from the very beginning, in the IAP services, at the very beginning from referral, the young people are either phoned up or brought into face-to-face, probably online now, for an assessment. And this assessment is 45 minutes. And within it, there's a lot of demographic information taken, but also almost the very first thing they're asked is, do you self-harm? Have you self-harmed? Have you self-harmed in the last 14 days? And will you continue to self-harm? Now, for a lot of young people, that took away the control of them saying if they self-harmed or not. It was forced out of them, they felt, which sounds a bit odd considering they've gone to therapy for help, and they maybe part of that referral was for self-harm. But the young people felt that to be asked straight off on the first assessment, it was too much. It was shocking. There was fear around, you know, would they tell the parents? A lot of the parents didn't know, for example, that a young person self-harmed and they've been sent by the school or been asked by the school to be referred. Many of them were worried, even to the extremes, that somebody would come around and take them away and put them in a mental health hospital because of the self-harming. Others, those of who I don't think it's cruel to say were veterans of the mental health services already at a young age, were quite blasé about saying if they're self-harm because they were familiar to that process. But the point being that it was taken out of their control. This assessment, as I say, is very short and sharp and quick, and the person making the assessment then makes a decision based on the information on whether they're going to have low intensity CBT, counselling, or high intensity CBT. And at no point are they asked, as I said. So the whole sense of control when they come to therapy hoping to gain control is actually taken away from them in the very first instance. But through therapy, looking at where control can be had or where control might not be had, and building some level of acceptance in, the young people did feel that their hopes were met. The second thing was change the way they see things, which links into the first thing. Again, seeing where control was not possible, or seeing where they had no say in what was happening, but how they could act differently or think differently, or even, as a CBT colleagues would call it, reframing the thinking. I'm a person-centered in my core of therapy, but I do like some of the ideas of CBT, and that's why I really do like pluralism as well. So this reframing the thinking, because sometimes the young people, especially when the parents were involved, were being punished or being controlled or being restricted by the parents. They felt punished, but if by helping them to see that actually that's the parents' way of caring, or the parents' way of showing love, by helping them in the best way they can, although perhaps ill-equipped or ill-informed, changing the way they see things can change the perspective and help them to understand a little bit better. The things that really helped, so part of the thing was did you achieve your goals, and what helped you in achieving your goals? What they in person-centered world would call the core conditions of empathy, acceptance, and congruence, but that shines through on all modalities of therapy. And it was the therapist space, the kindness, the lack of judgment, the lack of punishment, the lack of criticism that the young people found was really, really beneficial to helping them feel at ease, feel at rest, talk freely. And that's well documented throughout literature of that sort of therapeutic space being a positive one, and they weren't going to get told off, which leans into theme 4, the consequences of admitting self-harm. Which goes back to what I said earlier about in the assessment, the young people thought they were going to be punished or somehow, or they were going to be taken away. There's one person I remember very distinctly. I'm sure this doesn't happen now, but she felt she was going to be taken off in a straitjacket because she self-harmed, and taken off to a mental and the police. And how that had got into her mind was unclear in the research, but that's why she actually said she didn't admit to self-harming for quite a few sessions. So it all comes under the control and that sense of giving the young person some agency in what's happening to them and how they help with their problems and things like that. And that's where pluralism for me comes in, that not everybody needs the same things at the same time. Some of these young people were quite happy with a more directive CBT way of doing it, and others didn't do very well in a cognitive behavioural sense. In fact, one person dropped out of treatment, as they say in the NHS, dropped out of treatment after 2 sessions because her therapist was being quite directive and wanting her to speak about issues that she didn't want to speak about. Another of the participants unfortunately dropped out of treatment because the NHS service insisted on her travelling 30 miles to have her therapy sessions delivered to her, and she couldn't make it. She had, one of her issues was social anxiety. She couldn't go on the bus to get to the centre that she needed to go to, and it seems from what she said that she tried to say this, she needed a friend to go with her, and she couldn't always get friends. Her parents weren't able to because of disabilities. So in the end, she dropped out of treatment because she wasn't able to attend the sessions, which I personally thought was quite shocking. And one of my difficulties in all of this was I was actually employed by the service that was delivering the therapy. So it was quite an interesting position to be in. So the young people who self-harm and engage in therapy are seeking to feel more in control. I mean, this is a snapshot of 10 people. Thinking back to what John McLeod said about averages are only dependent on the sample you're looking at, aren't they? But for the sample I looked at, control was a big factor. Feeling more in control, feeling they had more say in what was going on for them. They didn't feel in control in therapy services. It was the general consensus was that therapy was being done to them rather than with them, as far as the service goes. But in the therapy sessions, that was more a sense of feeling alongside and feeling with them. And every single one of the people I interviewed, including the ones who dropped out, did stop self-harming by their own admissions. And one of the reasons was, they felt more control, but one person actually reported that it wasn't the therapist that helped them. She was the one who dropped out after 2 sessions, but it was her friends. The supportive, open, accepting relationship she had with her friends helped her to feel better about herself, and then helped her, then she stopped self-harming. But the whole point of my thesis in the end, the summary comes down to, let's allow some young people some control as much as possible, because what we're doing in therapy or within the IAP service is exacerbating the problem, not exasperating the problem. And let's concentrate on the cause of self-harm, not self-harm itself. Because one of the things that came up quite often was it's a very high focus on harm minimization techniques, or even one person said that their therapist had enacted a contract that they wouldn't self-harm between now and the next session, which, different views. My personal view and their view was that it just led to them lying to the therapist, and then that was causing a rupture in the therapeutic alliance, because they didn't want to lie to the therapist, but they felt they had to lie to avoid feeling chastised or feeling that they'd let the therapist down because they hadn't been able to not self-harm. Whereas I believe, and from the therapy and from the evidence and from my own personal clinical experience, more concentration on what is causing the self-harm will lead to the self-harm being lessened or even stopped. And I don't know how much time I've got left. I've probably finished a bit early, but I would welcome some questions if there are any.
Yeah, thanks for that, Mark. We've got 10 minutes. Was there something else you wanted to add?
No, but I'm welcome to some questions if you want. I've done it. The problem is it's a very small piece of all the work, and it's trying to. But I've been welcome some questions or some thoughts coming back. But be kind. I'm very new at this sort of thing.
No, that was great, Mark, and I think you're right. Distilling 7 years of work down into a 20 to 30 minute presentation is no easy task. I wonder if you stop sharing your screen and then we can see if people have got any questions, anything you want to comment with.
If I could work out how to stop sharing, I would. Oh, there we go. Big red. There we go.
Brilliant. Perfect. Any thoughts, comments, questions for John? We've got one from Vic. How do you manage contracting with people who are self-harming? Any thoughts on that, John? Mark?
It's quite an honour to be called John. In my current role, the contracting is done for me. It's all part of a process beforehand. In my private practice, I'm probably going to say something which is quite, I don't know how it'll go down, but I don't contract about not self-harming. And I say to the young person, if you need to feel the need to self-harm, do so, but please take care of yourself, and please, I would never say to somebody who has a therapy with, do not self-harm, you must not self-harm, or anything like that, because it takes away their coping strategy. And it might seem quite shocking to some people. Some organisations do have a no harm clauses and contracts, but mine doesn't, and I don't in my private practice.
Yeah, it always seems to me to completely misunderstand what self-harm is about. People are contracting to try and take it away as a coping strategy. And I think the concept of safe self-harm is really respectful, actually, and really important. Kate, you have your hand up. You got there.
Okay, hello.
Hello,
Mark.
Kate.
Thank you so much for this work. It's really interesting. I want to ask you a question actually, which Andrew might be able to help you answer, and it's around risk. So a lot of, I think, organizational strategies are around the association of self-harm with suicidality. It's almost, the old narrative was that they were bundled up together. If you were self-harming, you were at risk of suicide. Were you seeing any of those kinds of things coming through in your work? Was there an association, or are you seeing self-harm as very much a sort of separate, as you say, strategy?
I'm in the separate category. As a lot of young people will tell you, and they have said to me, and I'm sure they've said to others, self-harm is a way of surviving, not a way of stepping towards end of life. There may be cases where suicidal intent is because the self-harm doesn't meet the needs anymore, or something happens again. But I'm in the general category. I know there's so many names for self-harm, isn't there, out there? But the one non-suicidal self-injury, the categories of that. And that's been based on my clinical experience, but none of the 10 participants had any suicide attempt. Not everybody was cutting. Some were using, I forget the fancy names, pulling the hair out or punching themselves. And there's also that line, a line that I still haven't quite sorted out. Is an overdose self-harm, or is it a suicide attempt?
I suppose only the client would be able to
know. Yes, and I come very much from that. Only the client would know. I have had cause to concern with, not with the people and my participants, but somebody who, to hide the scars on their arms, they were cutting the inside of their legs, and they hadn't realised about the main artery or vein, or the not the femoral artery, isn't it? And they hadn't realised that they could cut that. So sometimes my therapist actually came into actually a bit of a "don't cut there, please" moment. But I think my own personal philosophy, and from working with young people for a long time, is my experience is suicide and self-harm are related but not together. One doesn't necessarily, the self-harm doesn't necessarily lead to suicide.
Yeah,
Andrew, more experience on that than me.
Thanks for that, Kate. Gary, you have your hand up.
Hiya, sorry, I'm still getting used to not being able to unmute. Thank you, Mark. That was really interesting piece of work, and I thought you'd conveyed sort of 7 years of work really well into a 20-minute presentation, which is really difficult. My background is sort of similar, although I tend to work with children, young people a little bit younger. One of my questions was around preference. So you've gone through your slides, but I'm wondering, did the young people give any idea of preferences around how they would like that self-harm managed better, or how they would like to talk about that in the therapy room, or how that would be easier for them to engage in those services in a better way?
That didn't come up in the research because I didn't ask that question basically, so they answered the questions that were asked. Self-harm management, was interested to hear about how many people use harm minimization techniques, and a lot of them said no. And this is obvious when you think about it. Tying an elastic band against your arm still hurts. It's still painful, and it wasn't changing the way they're thinking around self-harm. So instead of cutting themselves, yes, they weren't causing any skin injury, but they still had that mindset that if things are going wrong or things are difficult, I'm going to hurt myself by elastic band or ice cubes. But it didn't particularly come up in the research.
Brilliant, thank you. Thank you for the question, Gary. Imogen.
Hi, Mark. Thanks
Hi.
very much for a really, really interesting presentation. And I just wanted to ask you something. It was really interesting at the end where you said about an increased sense of control can lead to lessening or even stopping self-harm behaviours. And I was wondering whether the young people you interviewed said very much about the cause of self-harm, whether it was a personal thing or whether it was a more systemic thing within society.
It's interesting. The young people in the research had some other emotional difficulty that they were coping with through self-harm. They felt that some had body dysphoria issues, some had family relational issues, and I talk about a lot about the family relationship in my thesis, but there just wasn't time today to about how families impact self-harm. A lot of them, there was one person who was going through the change to transgender from male to female, and they, while they were in the wrong gender in their sense, that led them to self-harm. And it's all from my participants, all out of emotional distress. But I have in my clinical work come across people who self-harmed. One person self-harmed because they said, well, they noticed people who self-harm were getting a lot more attention from the school and from teachers, so they self-harm to gain attention, which contradicts the thing that young people self-harm for attention seeking. That's not what I'm saying, but this person. And interestingly, I once had one person who self-harmed because she saw it hurt her mother. She hated her mother so much she self-harmed to cause her mother pain. That was 2 years of work, that one was. But so, like, to use a pluralism thing, there's no one person at one time is the same. Everybody's different. Each case of self-harm will be different, unique and individual to that person. That's very clear from my research and from my clinical experience.
Thanks very much.
Thank you, Imogen. And I think we probably need to draw it to a close because we've all got to do a little bit of a technological shimmy to get across to room one. But before we do, I wanted to thank John Hills and John McLeod and Mark Plant, 3 fantastic presentations, fantastic papers, and